Hello, everyone, and welcome to the March 2026 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Alice Cheng from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania, and we are your co hosts for this podcast series.
Well, welcome to March, everyone. I don't know if you know this, Mike, but every year, the fourth Tuesday in March is Diabetes Alert Day, a day set aside by the American Diabetes Association to raise awareness of the seriousness of diabetes and the importance of knowing one's risk. So if you live in the United States, watch out for activities marking this day in your area.
And Alice, I believe there is something else exciting that we will be starting in March 2026. The ADA has a new podcast called The Points of Care. It is a companion podcast with short, focused conversations highlighting practice relevant insights from the new ADA journal, Diabetes, Obesity, and Cardiometabolic Care. The Points of Care podcast can be heard through the Diabetes Core update feed, so please check it out.
Always good to have another avenue to stay up to date in this ever changing and rapidly changing landscape of not just diabetes, but also obesity care. So, Mike, are you ready for the question this month to get to know us a bit better?
I think so.
Okay, this one's easy. This is not difficult. So, Mike, why did you choose endocrinology as a career path?
Well, so Alex, there's a moment that I share often because it was pretty clear to me when I was moving apartments in medical school with my wife and going through books to box or give away. I was leafing through my physiology textbook from college and noticed that the only section I'd bothered to highlight or scribble any notes in the margin in was the endocrinology section.
Ah.
And at this point, I'd been through biochemistry at Penn's Medical School and been fascinated by Franz Machinsky's lectures on diabetes. But I have to say, it probably was Frank Sterling's lectures during my second year endocrine pathophysiology course, which included on feast and famine, and that really anchored my appreciation of endocrinology as a specialty handling complex clinical problems in metabolism. And Dr. Sterling was always open to having students join him for his clinic at our Veterans Administration Hospital. And while Dr. Sterling saw all endocrine problems, he would explain diabetes is the bread and butter of endocrinology. And he was just a master and a gem of a person. And I found myself visiting him there in his clinic as often as I could.
And it's funny how the stories, whenever you ask anybody this question, there's often at least one or two or three inspiring individuals, right, that really leave their mark. My story is somewhat similar. I don't think I was quite as studious as you, though, I will admit that. Like most people, I had never heard of endocrinology before starting medical school. I had no reason to have ever had met one. So I went into med school thinking I'm going to be a pediatrician because the coolest person, coolest adult I had ever met was my own pediatrician. At least that was my perception then. So I wanted to be like her. So I went into med school thinking I'm going to be a pediatrician. Then I did my first clinical rotation in pediatrics, and I realized I am not going to be a pediatrician because it just wasn't the right fit for me. Then I had the fortune of working with some really inspirational people early on in my medical school career, and people like Rob Silver, Larry Leader, Bernie Zinman, and they were just really inspirational and very generous with their time, and you could see how much they really loved what they did, and the rest, I guess, is history. And then also on top of that, as I went through the different specialties within internal medicine, endocrine made the most sense. It was if something is up, you try to bring it down. If something is down, you replace it. Like it was very reasonable and logical in my mind. So therefore, that's where I ended up staying. And then here we are, all these years later.
Well, you make understanding of regulatory feedback mechanisms just seem so simple, Alice, and so clearly I can only imagine how your ease of understanding those complex processes drew you to endocrinology. And I also often felt like endocrinologists always seemed to be needed for answering questions related to
Mhm.
feedback disorders that would mean that, hey, I should probably always have a job if I went into endocrinology.
True.
Well, with that, let's launch into the March 2026 episode of Diabetes Care on Air. We will conduct an interview with authors of future articles as per usual, followed by our rapid exchange segment where Alice and I will each pick 3 articles of interest to us.
Make it so. One of the feature articles from the March 2026 issue of Diabetes Care is entitled Global Estimates of Undiagnosed Diabetes in Adults, Findings from the 2025 IDF Diabetes Atlas by Dr. Felix Teufel and colleagues. I'm very happy to be joined by the lead author, Dr. Felix Teufel, from the Hubert Department of Global Health and the Emory Global Diabetes Research Center at Emory University. Welcome, Felix, and great to have you on the podcast, and congratulations to you and your colleagues.
Thanks so much for having me, Alice.
So, as our listeners know well, the IDF, or International Diabetes Federation, publishes a diabetes atlas on a regular basis, which provides an updated snapshot of overall diabetes prevalence globally with extrapolated estimates into the future. Now, among those aged 20 to 79, the 2024 prevalence was estimated at 11.1% of the world's population, or 588.7 million people. Now, the projection for year 2050 is 13%, or a staggering 852.5 million people. Now, the focus of your team was on the prevalence of undiagnosed diabetes globally. So my question to you then, Felix, is how was undiagnosed defined? Why is it important to identify that group? And is there a benchmark that's been set as to what the percentage of undiagnosed should be globally?
Sure. Let me maybe start with why I think this is important. As you as a clinician, and probably also many of your listeners will know, the first step to good diabetes care is getting people aware of their condition. There's a lot that needs to happen afterwards, but diagnosis is really the starting point of each patient's care journey. From previous literature, we know that getting patients diagnosed in time or not getting patients diagnosed in time can lead to delayed treatment initiation, increased risk of complications, and can also generate a lot of avoidable costs further down the line. And that's also why diagnosis constitutes one of the 5 targets from the World Health Organization's Global Diabetes Compact. It's actually even the first target. And the benchmark WHO set is for countries to get 80% of people with diabetes diagnosed by 2030, which is admittedly quite ambitious.
Mm-hmm.
And your listeners might wonder now or might be interested in how this gets measured and tracked. And often these types of estimates are based on national health surveys. What these surveys do is, on the one hand, they collect glycemic markers among a representative sample of participants. And on the other hand, they include interview questions on whether participants were ever diagnosed with diabetes by a health professional. And then those 2 pieces of information, so people's glycemic levels and also their self-reported diagnosis status, allows us to identify these 2 different groups of people, namely the ones with diagnosed diabetes and the ones with undiagnosed diabetes.
Okay. All right. That makes a lot of sense. I mean, it's logical. If we don't call it, we can't treat it. So I guess that makes a ton of sense. Okay.
Exactly.
So it's obvious a tremendous amount of work went into achieving your objective to determine the undiagnosed diabetes prevalence estimates for all of these countries and regions. So at a high level, how did you do this? What literature was used? What happened when country-specific data were not available, which was apparently the case in 49% of the countries? And what were the 6 steps or analyses that the team undertook in this particular report?
Yeah, thanks so much for those questions. So the IDF team, who were fantastic, by the way, led a tremendous effort to systematically screen for previous studies and survey reports in order to identify reliable data sources for estimating diabetes prevalence globally. There's various validity checks built into this process to really make sure that data meets quality standards. Now, when it comes to diabetes prevalence, around 250 data sources from 150 countries were included. And of those, 109 countries also had data on undiagnosed diabetes. And as you rightly pointed out, a key challenge for the global diabetes response is that not all countries keep tabs on diabetes epidemiology. And that's why for countries without that kind of data available, the IDF team developed an analytical approach to extrapolate information from countries that match in terms of geographic location, ethnicity, language, and income level. Now, I think you also asked about our analytical approach, and I might not bore listeners with all minute details, but maybe on a high level, what we did is we estimated the proportion of diabetes patients who were undiagnosed in each country. And then we combined that information from health surveys with demographic data in order to transform these relative estimates into absolute case numbers. And then we sliced up our findings by different world regions, by country income groups, et cetera. And lastly, as I mentioned in the beginning, we benchmarked those findings against a WHO diagnosis target.
Okay, very good. That was not the least bit boring, Felix. I'm going to say it was completely understandable. Thank you for that.
Thanks. I appreciate that.
Now, let's talk about what you found, right? So what was the prevalence estimate of undiagnosed diabetes globally, and how did it compare across different regions?
So globally, we found that 42.8% of individuals with diabetes were undiagnosed in 2024. That's around 250 million people, which I think is quite a lot.
That's a lot.
But what I find interesting is that there's a lot of variation in that estimate. So some countries managed to diagnose over 8 in 10 people with diabetes, whereas in other places, 90% of people remained undiagnosed. So if we compare regions, we, for instance, saw that levels of undiagnosed diabetes were particularly high in sub-Saharan Africa and South and East Asia, and relatively low in the Americas, for instance.
Now, you also did analyses relative to World Bank country income groups, as well as country-specific gross national income per capita. So what did you find there?
Yeah, that's very interesting, I find, because when we just look at where people with undiagnosed diabetes live, we will find that around 80% of them live in middle-income countries. So places like India, China, and Indonesia. And I think that's just a really important reminder for everyone as we think about how to address these things and improve care from a global perspective. And then on the other hand, what we found, and of course these are just correlations, but we found that wealthier countries that can afford to invest more in their health systems were doing better in terms of diagnosing diabetes patients. And this might be somewhat unsurprising, but what I personally find really intriguing here are the positive outliers. So countries that are doing really well in terms of getting people with diabetes diagnosed, despite having limited resources.
So what about reaching that WHO benchmark of 80% or more individuals with diabetes being diagnosed? So who made the cut? I'm sure our listeners are wondering if their country made the cut. So who actually made the cut for that WHO benchmark?
Yeah, so that kind of relates to these positive outliers I was talking about. Because if we look at it from a global perspective, we realize that only 8 countries worldwide are currently meeting the 80% diagnosis target of the WHO. That is Chile, Colombia, Czech Republic, Ecuador, Finland, Hungary, Jordan, and Poland. And whereas for some of these countries, for instance, Finland, I can imagine many people wouldn't be surprised that they're doing really well in terms of getting people with diabetes diagnosed. But I personally also, for instance, found it interesting to see Ecuador in there because they have less resources available to finance their healthcare system than, for instance, Finland. And yet they're doing really well. We definitely need more research to unpack what these countries are doing right. But for instance, in Ecuador, we know that the country invested a lot in strengthening their primary care system and ensuring universal health coverage for all people in the country. So I think this is a really interesting area for future research.
Absolutely. And I just want to reiterate to our listeners, only 8 countries out of all the countries that you looked at have actually met that WHO benchmark. And I suspect for some of our listeners coming from those 8 countries, well done, congratulations. But for the rest of us, we probably were hoping that Felix would mention our country, but did not. So there is still a lot of work to be done. And in the paper, you make an interesting point that the global prevalence of undiagnosed diabetes, and you've tracked it over different iterations of the Atlas, has improved by an underwhelming 3 percentage points in the past 10 years. So why do gaps in diagnosis happen?
There's, of course, a lot of nuance in this and a lot of heterogeneity across different countries and contexts. But I think on a high level, I'd say there's two factors playing a role here: service delivery and service uptake. Regarding the service delivery side of things, that's a bit what I've been alluding to before. So I think in many countries, patients with diabetes, they cannot really access services for diabetes prevention and care because they tend to be quite expensive, inaccessible, or they just simply do not exist. But then on the other hand, we have the service uptake part, which is even when there is decent healthcare around, patients might still not make use of it, either because they don't trust the healthcare system or because they're not aware of the dangers diabetes can pose to their health and livelihoods. So next to strengthening health systems, I think it's very important to continue building awareness around diabetes.
Absolutely. So what are the implications then for health policy and for population health? And what can we learn from each other? In other words, where do we go from here?
Well, learning from each other is actually a great starting point because there really is no one size fits all solution for addressing the global diabetes epidemic, particularly because more than 4 in 5 people with undiagnosed diabetes live in low middle income countries. I think it's really important that researchers, clinicians, patients, and policymakers work together to find smart ways for scaling up cost effective diabetes screening strategies that are accessible for everyone. And coming back to the beginning of our conversation, diagnosis is really just one aspect of this. Beyond diagnosis, the goal of good diabetes care is to empower patients to manage their condition, provide access to evidence-based treatments, and support them over long periods of time to help them meet their personal health targets.
Fantastic. Thank you. Thank you very much, Dr. Felix Teufel, for sharing your expertise with us today, and to you and your colleagues for doing this extremely important work, which will certainly advance diabetes care globally. I'm sure everyone listening wants to know where their country sits, so please check out the paper for more details. I personally looked up Canada, of course, and we were sitting at 28.9% undiagnosed, so not far from the benchmark, but not close either. But I noticed that our data were from 2011, so it's actually on us to generate more up-to-date data. And for our listeners, again, when you're looking up your own country, you can take a look at the actual date that the data sources came from. And then if it needs to be updated, maybe that's something that you can work on. And huge kudos to Chile, Colombia, Czech Republic, Ecuador, Finland, Hungary, Jordan, and Poland for achieving the WHO diabetes diagnosis targets. We all can learn from what you have achieved. So thank you again, Felix, for joining this podcast. And I encourage our listeners to read the full article in the March 2026 issue of Diabetes Care.
In the March 2026 issue of Diabetes Care is a feature article entitled Toward Disease-Modifying Therapies in Type 1 Diabetes, Focus on Teplizumab. I'm delighted we have joining us the article's first author, Dr. Chantal Mathieu. Dr. Mathieu is professor of medicine at the Katholieke Universiteit Leuven in Belgium and serves as chair of endocrinology at the University Hospital Gasthuisberg Leuven. Welcome, Chantal.
Hi, Mike. Pleasure to be here.
Congratulations to you, Chantal, and your co-authors on this feature article. Now, even focusing just on teplizumab covers decades of science. I was hoping you could start by telling us how you and your co-authors got together to write this paper and tell the present story of teplizumab.
Oh, this was a long story, let me tell you. So, as you can imagine, people like Lucien Chatenoux, Mark Atkinson, Kevin Harold, and myself, we meet up as older generation people quite a few times a year in all kinds of meetings. And very often we give talks to clinicians. And these are the people now, the endocrinologists, the pediatricians, who are treating people with teplizumab. And very often they come to us and they say, all these very complicated explanations on immune cells, that's all fine, but just give me the in a nutshell message. And so we got talking, and we had this idea we need to make a concise review where we bring together everything we know about teplizumab, but in a language that non-immunologist clinicians would understand, namely the pediatricians and endocrinologists. And also, to have it in the context of everything we've learned about the pathophysiology of type 1 diabetes and also where this field is going. So it was really almost, at the bar discussion, let's do this, that we started this way. And then Eddie James came in, and then our master of ceremonies, Dr. Emily Sims from Indianapolis, was really the driver, and she was amazing in criticizing the old crocodiles in what we wanted to say. And she really pushed us to bring the message in a way that was relevant for clinicians. So it was a fun ride putting together this manuscript.
Well, I'm really glad you all did so. Your article nicely takes us through three key topics related to teplizumab as a disease-modifying therapy for type 1 diabetes: mechanism of action, clinical effects, and clinical considerations. So first, let's start with the mechanism of action. Can you tell us, what is teplizumab doing to T lymphocytes, and how does this interrupt autoimmune destruction of beta cells in type 1 diabetes?
So teplizumab is an antibody directed against a protein sitting on the surface of specific T lymphocytes, namely CD3. So it's a monoclonal antibody directed specifically against these CD3 carrying T lymphocytes. It was manufactured to have all the effects that we knew that antibodies against CD3 carrying T lymphocytes could have, but in such a way that the side effects that we knew with these antibodies against CD3 happened less. Side effects like fever when an infusion against CD3 carrying T lymphocytes is given. And so teplizumab was really manufactured specifically to target the CD3 carrying T lymphocytes in such a way that the side effects of this targeting of these T lymphocytes were less, but the effects were maintained. And so the effects being mainly the change in the behavior of these T lymphocytes. So what you see when you infuse teplizumab, it is an infusion that is given over 12 to 14 days, and it was designed in such a way that the people who gave us the advice how to infuse teplizumab said, let's start in very, very low doses. And so it's a ramp up in dose for 5 days and then maintenance at higher doses. And so by designing teplizumab in the way the manufacturers did, and then ramping up this dose over 5 days, they limited indeed the side effects of this infusion, namely the cytokine release syndrome. So fever, muscle pain, not feeling very well. But the effects are there. What are the effects? First of all, we see temporarily during the infusion of teplizumab, we see a decrease in white blood cell count, specifically in T lymphocytes. And there we know that it is partly a shift in the position of these T lymphocytes coming from the blood compartment to the wall of the blood, but also to the gut. So there is an egression, we think, of these T lymphocytes to the gut. And this is, of course, very interesting. We see that also happening in mice. We think that microbiome may play a role, and also that it also plays a role in the generation of regulator cells. So we know that in any autoimmune disease, but also an autoimmune disease like type 1 diabetes, there are attacker T lymphocytes against the beta cell, and then regulator T lymphocytes, keeping the attackers in check. And so what we see with teplizumab is that there is an increase in these regulator cells that keep the attackers in check. And also we see a decrease in the attackers. So it seems to be a multi-pronged effect of this monoclonal anti-CD3 antibody on these T lymphocytes. More regulators, displacement of T lymphocytes, and also less attacker T lymphocytes. But as said, through the design of the monoclonal, less side effects during the infusion, less of this cytokine release syndrome, less fever, muscle pain, etc. Also due to the ramping up of the dose.
Well, that's really helpful to understand and appreciate. And as we explain this treatment and the rationale for the multiple days to our patients who are receiving it, and also to understand how this therapy is really tipping the balance then away from autoimmunity and closer towards tolerance of those remaining beta cells that we hope to preserve in individuals with type 1 diabetes. And so, moving now to the clinical effects that are seen, what do we know about the effects of teplizumab to preserve residual islet beta cell function in stage 3 type 1 diabetes, as well as that to prevent progression from stage 2 to clinically overt stage 3 disease where the drug is approved?
Yeah, so perhaps we should go back to this new nomenclature in type 1 diabetes, where we as older clinicians were used to say that the diagnosis of type 1 diabetes was made when hyperglycemia and thus polyuria, polydipsia, etc. existed. Now we call that, as you said, stage 3 T1D, because we now want to make the diagnosis of type 1 diabetes much, much earlier, namely when 2 or more autoantibodies against beta cells are present in the blood. And so that moment when we see for the first time 2 or more autoantibodies in the blood of people who are still normoglycemic, we call that the beginning of T1D. We call that stage 1 T1D. When you have a stage 1, you have a stage 3, there needs to be a stage in the middle. And indeed, that is people who have 2 or more of these autoantibodies in their blood, indicating that the autoimmune attack against the beta cell is happening, but also are not normoglycemic anymore, but are dysglycemic when you subject them to an oral glucose tolerance test. And so teplizumab has been tested in quite a few trials over the years, more than 10 years now. We have experience with this agent. And indeed, in several studies where Kevin Harold was one of the main investigators, they have been able to show that a course of 14 days or a course of 12 days or a repeated course of 14 days of teplizumab after 6 months or after 1 year after diagnosis. So they tested different things, but every time they could show that if you take people with new onset clinical, thus stage 3 type 1 diabetes, you could see after a year and even after 2 years a protection of the functional beta cell mass as measured by stimulated C-peptide. And that is extremely convincing, Mike, to see that despite different dosing regimens, repetition of the infusion or not, it's always the same. You always have more stimulated C-peptide left in those who were treated compared to the placebos. In some trials, they saw an effect on hemoglobin A1C and on insulin dose, in others not, often to do with the background of the people, the duration of stage 3. It seemed that the biggest effectiveness was seen the younger the people were, the closer to the clinical diagnosis of stage 3 T1D they were. And interestingly enough, also in one trial, in the Protégé trial, they also saw that the effects were more pronounced in clinical trial sites in the US, probably reflecting people of Caucasian origin. So we know now quite well what happens in stage 3. namely a protection of the functional beta cell mass reflected by more stimulated C-peptide. The problem is that our regulators, FDA, EMA, have trouble. They have problems accepting stimulated C-peptide as an outcome measure. They see it as a surrogate marker, and they say it's fine for an early clinical trial to show the proof of concept. But if a company would like to market teplizumab in stage 3 T1D, they want at present hard metabolic outcomes like hemoglobin A1C and insulin dose. And there, some trials done with teplizumab have failed. And so new trials are ongoing to show it in even more people that indeed also in stage 3 T1D, teplizumab works. But where teplizumab is now approved by regulators in the US, in Europe, in Canada, in many, many areas of the world, is stage 2, namely individuals with 2 or more autoantibodies, with dysglycemia if you give them an oral glucose tolerance test, and who have approximately 75% risk of progressing towards clinical stage 3 T1D. In these people, teplizumab is now approved by our regulators for delaying the progression to stage 3 T1D, because that's what, again, Kevin Harold, the senior author of this review, has demonstrated in the TrialNet study, the TN10 trial, namely a delay of almost 3 years in the progression between stage 2 and stage 3 in individuals with stage 2 T1D with teplizumab. And again, very important data, one course, 14 days of this monoclonal, a delay of up to 3 years in these individuals.
That's great. And so, as that 14-day course is now being implemented in clinical practice and screening is expanding to identify family members of individuals with type 1 diabetes who may have 2 or more autoantibodies and dysglycemia, let's move on now to the clinical considerations that your article covers for delivering teplizumab in medical practice. We started to talk about the advantage of the dose ramp up over the first 5 days to minimize side effects. I think that's a really important message to understand. What are some of the other lessons learned from real world experience and data available to date?
Yeah, so the first thing is to get yourself organized and to make sure that your clinical center is able to do the infusion. There are very practical aspects like what will be the access for administering the teplizumab. We, for instance, in children, and until now in Europe, it is approved for use above the age of 8 years, but just now we will have the publication of the PETITE study where we have safety data in children as young as 1 year of age. But so in children, mostly PIC catheter is preferred. In adults, we use Medline approaches or peripheral catheters. So first of all, get your site organized, sit together with your nurses, decide who will prepare the agent. It's quite simple. As said, it starts with a very low dose day 1 and then ramps up to day 5. And then you have a stable dose the days thereafter. So organize your center, organize practical decisions, access, who will administer a drug. Some people use home administration. So it's really depending on the area where you are and the healthcare system you work in. Second, very important, is to organize the pre-medication. So acetaminophen, ibuprofen, antihistamines, and for some people who are very sensitive, also antiemetic agents. I can tell you that in my center, I'm very liberal with these pre-medications so that people really tolerate it very well. For sure, you need to do this in the first 5 days. I tend to also use it in the days thereafter and let people themselves decide whether they want to bring down this pre-medication. Thirdly, you need to also organize the monitoring of these people, namely do a blood sample for a hemoglobin, white blood count, and liver function test before you do the infusion. And then day 3, you can decide for sure, day 5, and then at the end of the infusion. Because there you see 2 other side effects. I said before that one of the effects of anti-CD3, thus teplizumab, is to cause an aggression of the T lymphocytes from the blood. So you do see a lymphopenia with the nadir happening at day 5. So there you want to keep an eye on it to see if it's not going too low, because that may make you pause the infusion for 1 or 2 days before you resume. And second, also mild liver function abnormalities have been described with teplizumab. Again, if you would see rises in liver function tests that exceed 2 to 3-fold upper limit, again, you may want to pause the infusions for 1 or 2 days. But so get your center organized, discuss with the team how will we do it, discuss access, organize pre-medication, and then also organize the monitoring. But then that's really it. It's very easy. And again, in our center, we, after the infusion, follow up these people in our early stage T1D clinic that we just started a year ago, where we follow up people in stage 1 and stage 2 T1D, a very new entity of people that we didn't know before. So these are people with antibodies who are normoglycemic or dysglycemic. And so there we also follow up people who have now received before teplizumab.
That's really great. Super helpful, practical advice, Chantal, to all of us who are now seeing these individuals and helping them make decisions about treatment, but also, as you point out, importantly, the monitoring, both of the potential effects of the treatment, but also those that may not yet be eligible for treatment and who may reach eligibility at some point in the future, and understanding how to continue to follow those individuals and keep them in our practices so we can advise them and their referring clinicians about their future care. And in terms of the tolerogenic effects that we talked about with teplizumab that clearly have benefits, as you said, in protecting the functional islet beta cell mass following administration, these effects, however, still appear to be relatively short-lived. If diabetes onset is delayed by 3 years, or in clinical trials, beta cell function is preserved over 3 years, but then at some point there is a recapitulation of the autoimmunity. And so, over an individual's lifetime with the disease, what is currently being investigated to further expand on efficacy, durability of disease-modifying therapy, building off of this experience we have with teplizumab?
As you know, Mike, we're living the most exciting times in type 1 diabetes, where finally our research in the pathophysiology of this disease is, bringing us the fruits, where we now, through our better understanding of this disease, find better points of attack. And it is clear that our immune system is extremely clever and has different pathways to again and again restart the attack on the beta cell. And so, whereas we see that effects of teplizumab are quite long-lived, we can find months and years after the administration still changes that we can pick up. And still, we see that in several individuals, the autoimmune process restarts or just progresses. And so, we need new therapies. Teplizumab is such an important milestone, but it's not the final one. I am sure that better therapies are coming. So I can tell you worldwide, more than 10 clinical trials are now happening with different immune modulatory agents For instance, agents that target cytokines, agents that target the JAK, so kinases that play a role in the immune system, many different interventions. Also, a humanized form of anti-thymocyte globulin, so what we tested in our MELD-ATG trial with anti-thymocyte globulin. So now there's a company making humanized anti-thymocyte globulin. So many different trials ongoing, looking at different ways to interfere with this immune attack against the beta cell. But interestingly also, trials ongoing looking at ways to harness the beta cell, to make the beta cell resist better to the attack of the immune system. Because what we know is that the beta cell is not a sitting duck undergoing the attack of the immune system, but it plays a role itself. We showed, for instance, many years ago that when a beta cell is under attack, instead of dying silently, it starts to secrete chemokines, calling in more cells of the immune system. And so, again, I already mentioned the JAK inhibitors, like baricitinib, for instance, which has been tested in the BANDIT trial and is now being tested worldwide in several studies. These kinases are also present in the beta cells. And so these JAK inhibitors may not only target the immune system, but also the beta cell. We have the studies with verapamil. And although the jury is still out whether verapamil itself is what we want, some confusing data there, but now we have more specific TIC-SNP targeting agents that may make beta cells stronger. Also, agents looking at proliferation of beta cells. So the most exciting times where you can feel that, yes, immune modulation, beta cell protection, you can feel that we're going to combinations of immune modulatory agents, but what excites me most is combinations of immune and beta cell protecting agents, so that you may address both sides of this dialogue of destruction in type 1 diabetes. And yeah, things are moving. We are getting the results of these trials in people with early stage 3 type 1 diabetes, so early stage clinical type 1, but now also more trials in stage 2, and we even have trials in stage 1, so in people just with autoantibodies, and still plenty of functional beta cell mass left. So I am now really fighting very hard to inform people how important it is to screen for early stages of type 1 diabetes, because we will get tools in our hands to really arrest this disease. And the more beta cells there are left to be saved, the bigger the impact it will have. If we do our interventions in people with new onset stage 3 T1D, there's only 20-30% of beta cell mass to be saved. Whereas if we can do it early on, we can keep people off insulin, and that will make a dramatic impact on the lives of people with type 1 diabetes, but hopefully without insulin. So it's the most exciting times, many new agents being tested. And I specifically look forward to combinations of these new agents, because what you asked is durability of effect. You can repeat the infusion of teplizumab, but many people develop antibodies against teplizumab, and so then it becomes futile to re-infuse. And so I more believe in combining different agents as time goes by in an individual, where you may attack different members of the immune system that play a role in the destruction of the beta cell.
Well, Chantal, that really is wonderful explanation and provides terrific hope for the future of, as you say, the fruits of the labor, understanding this dialogue between the immune system and the beta cells, and how targeting complementary pathways that are involved can lead to even better therapies and one day eradicate type 1 diabetes as a disease would be really wonderful to think about for the future. Dr. Chantal Mathieu, thank you so much for sharing your expertise with us today. I really appreciate all that I've learned from your article and our discussion about the role of teplizumab as the first clinically approved disease-modifying therapy for type 1 diabetes, but importantly, the really promising outlook for the future and what we should be doing now in readying ourselves to care for the individuals in earlier stages of type 1 diabetes. I encourage our listeners to access the full article in the March 2026 issue of Diabetes Care.
Let's move on now to the Rapid Exchange segment, where Mike and I will discuss articles we found of particular interest this month. Mike, can you kick us off, please?
Sure, Alice. My first pick examines whether progression from stage 2 to stage 3 type 1 diabetes differs between those living in North America and Europe, as well as between individuals who do or do not have a first degree relative affected by type 1 diabetes. Ms. Melanie Koger from Helmholtz Munich in Germany and colleagues compared time to progression between those individuals enrolled in the placebo arm of the TrialNet Teplizumab trial that was conducted in the United States and Canada that involved individuals who all had affected first-degree relatives, and looked at progression in those individuals enrolled in the FRIDA population-based screening program in Germany, which included about a third of individuals who had affected first-degree family members and about two-thirds that did not. The authors found that time to progression from stage 2 to stage 3 type 1 diabetes was similar among the 32 TrialNet participants, the 45 FRIDA participants who also had an affected first degree relative, and the 107 FRIDA participants who did not have an affected first degree relative. And so these findings help to provide reassurance that effect sizes for interventions designed to delay progression of type 1 diabetes may be generalizable from North America to European populations, and also importantly, from those with to those without a family history of type 1 diabetes who may be identified through broader population-based screening.
Thanks for sharing that, Mike. I mean, it's useful information given that we know the vast majority of people newly diagnosed with stage 3 type 1 diabetes does not have a family history of type 1 diabetes. So therefore, if we're going to implement this broadly, we are certainly going to identify a lot of people who do not have a family history. So knowing that the progression seems to be similar is very useful information. So that's great. Thanks very much for sharing that. So my first pick this month is an important randomized control trial in the gestational diabetes space by Dr. Chun-Heng Kuo and colleagues from Taiwan called the TESGO study. The question they wanted to answer was whether universal earlier screening for GDM with a 75-gram OGTT at 18 to 20 weeks gestation would improve pregnancy outcomes compared to standard screening at 24 to 28 weeks gestation. The primary outcome of interest was a composite of primary C-section, birth weight greater than the 90th percentile, neonatal hypoglycemia, cord serum C-peptide greater than the 90th percentile, gestational hypertension, preeclampsia, and birth trauma. The study included 967 singleton pregnant women and was stopped early for futility after a planned interim analysis. The primary outcome was not significantly different between those who were screened at 18 to 20 weeks compared to 24 to 28 weeks. The only differences seen were less neonatal hypoglycemia with the earlier screening, but there was more neonatal adiposity too. Bottom line, this study showed that universal earlier GDM screening at 18 to 20 weeks may not improve pregnancy outcomes compared to currently recommended universal screening at 24 to 28 weeks gestation, reassuring for now that what we're doing seems to be okay.
Yeah, Allison, this brought to mind for me a number of studies we've seen targeting higher risk groups of women for earlier screening. And so I think for universal guidelines, yes, we should be reassured, but still there may be targeted groups where earlier screening might lead to improvements in maternal and child outcomes. And so I hope to see ongoing work in those areas. My second pick evaluates a fully closed loop system called the Automated Insulin Delivery as an Adaptive Network in type 1 diabetes using a randomized crossover study. Dr. Marcela Mascasco Vasquez from the University of Virginia and colleagues randomized 34 individuals with type 1 diabetes to the fully closed loop system or usual care. And for this group, almost everyone involved was on a hybrid closed loop system. And then that was followed by the alternate treatment, each over an approximately 5-day inpatient followed by 7-day outpatient period. For the cohort that was recruited with suboptimal glycemic control, the fully closed loop system achieved significantly improved CGM metrics of mean glucose and a more than 5 percentage point increase in time spent in the target glucose range when compared to usual care. And these benefits were largely driven by the subgroup whose hemoglobin A1C was greater than 8%. And so these findings suggest that for individuals that are struggling to optimize announced meal bolus delivery and not meeting glycemic control targets, that a fully closed loop system may provide a viable alternative with less user burden.
And I think that's something that everyone would welcome is a fully closed loop system to remove the current requirement or expectation of announcing meals, right? So if there's a way to get around that, that's great. And it's wonderful that it showed particularly benefit for those with higher A1Cs to begin with. But then I would think that even if it's similar A1C for those who are already achieving target, it's less work being in a fully closed loop compared to a hybrid, right? So ultimately, I think it's a great goal to be striving for. My second pick is about pathophysiology for a change. Dr. Maurizio Di Marco and colleagues from the German Diabetes Study Group sought to determine the role of glucose and insulin metabolism on pulmonary function across diabetes subtypes and those with normal glucose tolerance. Yes, you heard me right, pulmonary function. We're going to talk about the lungs. Over the last 15 years or so, there has been increasing recognition of the association between diabetes and pulmonary disease, including COPD, pneumonia, and pulmonary fibrosis. Both type 1 and type 2 diabetes have been variably associated with a reduction in forced expiratory volume in 1 second, or FEV1, and forced vital capacity, or FVC, compared to those with normal glucose tolerance. The mechanisms connecting pulmonary alterations and dysglycemia are unclear. This study utilized data from the ongoing German diabetes study, in which individuals with recent onset type 1 and type 2 diabetes and people with normal glucose tolerance underwent extensive comprehensive phenotyping. All of the participants with available spirometry data were included in this analysis, which meant there were 462 participants with type 1 diabetes, 482 with type 2 diabetes, and 244 with normal glucose tolerance. They underwent a Botnia clamp to determine insulin sensitivity, secretion, and clearance. They found that higher insulin sensitivity and clearance were associated with higher FEV1 and FVC. Compared to type 1 diabetes and controls, those with type 2 diabetes had lower FEV1 and FVC, which associated with insulin sensitivity. FEV1 was associated with daily insulin doses in type 1 diabetes, as well as with the presence of type 2 diabetes, severe insulin-resistant diabetes, and mild age-related diabetes. Mendelian randomization analysis supported a causal association between HOMA-IR and lower FEV1. Taken together, it appears that lower FEV1 and FVC in diabetes are linked to insulin resistance, impaired clearance, and higher insulin doses, all of which result in higher insulinemia, supporting the possibility that circulating insulin may have direct, independent lung effects.
That's really interesting, Alice, and makes me wonder about inhaled insulin and where acute concentrations of insulin are higher post dosing, but the clearance is much faster than with subcutaneous delivery. And so chronic exposure may be lower. And so, anyway, I think that's just a fascinating association that we should be all paying more attention to. My final pick addresses the development of impaired awareness of hypoglycemia in type 1 diabetes and comes from Dr. Austin Matus at the University of Pennsylvania and colleagues that happens to include myself as Austin's former postdoc mentor. But this is a study that Austin really led together with Dr. Alice Lin at University of Michigan. And it's based on the observation that we know hypoglycemic exposure appears necessary, but is not always sufficient for the development of impaired awareness of hypoglycemia. And that's because we know some adults with type 1 diabetes, but not others, develop impaired awareness of hypoglycemia with similar hypoglycemic exposure. And Austin recently identified that interoception, which is the ability of an individual to sense and interpret internal bodily sensations, is associated with a lower risk of having impaired awareness of hypoglycemia in type 1 diabetes. So Austin and Alex administered validated questionnaires for interoception and hypoglycemia symptom recognition to 717 participants from the type 1 diabetes exchange registry while capturing 30-day continuous glucose monitoring data. And what they found, as expected, that the higher hypoglycemic exposure was associated with lower hypoglycemia symptom levels. But now, importantly, also that having greater interoceptive awareness attenuated this association. Thus, it seems that interoception moderates the relationship between hypoglycemia exposure and the development of impaired symptom awareness. And so this may represent a novel target for interventions aimed at restoring awareness of hypoglycemia for affected individuals.
See, I always learn from you, Mike, but this is another example. I had never heard of the word interoception, and I really like it. I'm going to try to use it in a sentence today. It's a really good word, and as I'm listening to you, I'm thinking, I wonder what my interoception is. And it sounds like there's a questionnaire I could potentially take, but I also wonder, not knowing about interoception, as I just learned about it, are you born with a certain level of interoception? Can you train interoception? Can you modify it? I mean, there's all sorts of questions that are popping up in my brain, and this is very cool. Very cool indeed. Thank you, Mike. You've educated me yet again. Now, my final pick is an interesting study by Dr. Guoying Wang and colleagues from Johns Hopkins University and Boston University that investigated whether maternal diabetes in pregnancy was associated with altered neonatal global IgG repertoire and early life infections in offspring. They conducted a prospective birth cohort study of over 2,700 mother-infant pairs at the Boston Medical Center, specifically looking at rates of maternal and infant infections from electronic medical records, as well as cord blood IgG antibodies. 327 infants were born to mothers with GDM, and 138 were born to mothers with pregestational diabetes. Of the total over 2,700 infants, 15.4% had at least one infection in the neonatal period, and 52.7% had at least one infection in the first 6 months of life. Compared to maternal normoglycemia, both maternal GDM and maternal pregestational diabetes were associated with higher infant infection risk in the first 6 months of life. The associations were greater among preterm infants, those delivered via C-section, or those who had lower IgG repertoire diversity. As for IgG repertoire diversity, only maternal pregestational diabetes was associated with lower global IgG repertoire diversity, whereas infants of GDM mothers were indistinguishable from infants of mothers without diabetes. Some of you may be wondering about the impact of maternal hyperglycemia, and as expected, maternal hyperglycemia was associated with higher risk of infant infection, But the study highlights that there are additional risk factors beyond maternal hyperglycemia, which we may think is in fact modifiable, but there probably are other factors at play as well.
Thank you, Alice. And of those factors, this study makes me think about how important maternal vaccination is to prevent infectious disease in offspring, and how those vaccines may be even more important based on this evidence for women with diabetes affecting their pregnancies, and certainly something to look into. Well, this brings us to the end of the March 2026 episode of Diabetes Care on Air.
I want to say a huge thank you to Dr. Felix Teufel and Professor Chantal Mathieu for sharing their expertise with us.
Reminder to all that the ADA has a new podcast series that you can check out called The Points of Care, which is a companion podcast to the new journal Diabetes, Obesity, and Cardiometabolic Care, which highlights timely practice-relevant insights across diabetes and obesity care teams.
And as always, remember that the Diabetes Care Journal is continuing to take submissions of original art for consideration to be included on a future journal cover. So don't be shy, submit your work.
And don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening to another episode of Diabetes Care